Good afternoon. Thank you for joining today's webinar, COVID-19 and Safe Operations, What You Should Know. By attending today's webinar, you are eligible to receive 1 hour of continuing education credit. An email regarding how to apply for your CE will be sent to you at the conclusion of this webinar. We are excited to welcome our guest presenter for today, Mr. Tom Baldwin, Vice President of Safety for Global Medical Response. We will be turning the webinar over to Tom shortly, but first want to recognize our sponsors and share some webinar tools. NAMT would like to recognize our sponsors. On behalf of NAMT, we want to extend a warm thank you to LifeAssist, McKesson, and ESO for their continued support in advancing the EMS profession. LifeAssist is one of the nation's largest distributors of emergency medical supplies and equipment for the first responder, paramedic, EMT, and EMS provider. Since 1977, LifeAssist has specialized in customer service with customer satisfaction as their ultimate goal. Put simply, they treat customers as they like to be treated. McKesson's vision is to improve care in every setting, one product, one partner, and one patient at a time. As one of the largest healthcare companies in the world, McKesson plays an important role in the healthcare delivery and it is something they take seriously, even more so now as the world faces this healthcare challenge. ESO provides software that arms EMS for the data-driven world. ESO believes in the power of data to improve community health and safety. Today's presentation will include up-to-the-minute data from ESO's COVID-19 data dashboard, which includes data obtained from more than 2,600 EMS agencies across the United States. Handouts with references from today's discussion have been provided to you for this webinar. To download a handout from the session, click the name of the handout to access it. The handout file will automatically start downloading from your default browser. Click the downloaded file at the bottom and to save or open it. Please note that due to the size of today's webinar audience, participants' lines have been muted to maximize audio performance. We do, however, want to hear from you. At the end of this presentation today, we will conduct a question and answer session with Mr. Baldwin. Please take a moment to familiarize yourself with questions feature in the GoToWebinar toolbox and feel free to post questions for the presenter during this webinar. Please note that the chat box is not available through this webinar platform. While we do not anticipate technical difficulties, if you are experiencing any technical issues, please email webinars@namt.org. We're ready to get started. Once again, it's NAMT's pleasure to introduce Tom Baldwin. As the Vice President of Safety for GMR, Mr. Baldwin leads a 37-person professional safety team that supports 7,000 ground ambulances, 450 air medical aircraft, and 150 fire apparatus. He has been a leader of GMR's national COVID-19 response, responsible for the safety of the company's 38,000 employees, including critical frontline first responders and call center personnel, as well as the development of augmented safety protocols in the wake of this virus. Tom became a paramedic in 1991 and has worked in the fire service, law enforcement, and air and ground EMS communities. After serving in leadership roles in the aeromedical field, he transitioned to safety about 16 years ago. He is active in the air medical safety community as a member of the U.S. Helicopter Safety Team Human Factors Working Group and as a faculty instructor at the AAMS Safety Management Training Academy. He speaks nationally on a variety of topics, including safety culture, safety management systems, and just culture. Tom received his paramedic education at Creighton University and holds a BS in business management with a concentration in organizational leadership, an MBA in healthcare, and a professional certificate in aviation safety and security from the University of Southern California. Welcome, Mr. Baldwin.
Thank you, Cassie, and good morning or good afternoon, wherever you may be in EMS land. So first things first, let's get the legal mumbo jumbo out of the way. The attorneys say that I have to let you know that I'm not an epidemiologist, nor am I an infectious disease physician, and the guidance that we'll be discussing today is derived from CDC and OSHA. So As Cassie said, my name is Tom Baldwin. I'm the Vice President of Safety for GMR. And GMR is an organization of 38,000 employees. As Cassie noted, we've got over 400 aircraft, fixed and rotor wing. Got about 110, 115 fire apparatus and 7,000 ground ambulances. So GMR has been deployed into New York City, New Jersey over the past several weeks. We still have a lot of folks and a lot of assets out there. 1,700 responders have been deployed, 200 support staff, and about 525 ambulances to support the citizens of New York City and New Jersey. Within our own global medical response operations area, not unlike your own experiences, COVID has certainly had a tremendous impact on the organization and our providers. From about February the 1st to April the 27th, we have encountered over 100,000 PUIs, and each day we're seeing about 13 to 1,800 PUIs. One of the interesting things that we've noted is that our cardiac arrest rates are increasing in some areas. I've heard numbers as high as 50% from a prior year to some of our own regions here at GMR that are experiencing cardiac arrest rates that are 20% over prior years. So let's just revisit briefly a few things about the COVID virus. This is the novel coronavirus in the beta family. The alpha family is largely attributed to, say, the common cold. The beta virus, which we're working with now, consists of SARS, MERS, COVID-19. And what we know about COVID-19, we continue to learn a lot as this evolves, is that its primary mode of transmission is droplets, person to person. We do know that it is not airborne in the way that measles or tuberculosis is airborne. Transmission over long distances is very, very unlikely. Incubation time, 2 to 14 days with a median of 4 days. And I'm sure as we're all aware, standard contact and airborne precautions apply when we're dealing with these types of patients. If you're paying attention to the news, there's a whole lot of discussion right now about vaccines. There's no vaccine available, not yet. They're in work. I think we're all hopeful that we'll see something by late summer, early fall. Recently, CDC, within the past 3 or 4 days, I would say, CDC actually added to the list of symptoms associated with COVID-19. They're now actually referring to a patient having chills, sore throat, muscle pain, loss of taste, and headache as additional signs or symptoms associated with COVID-19. ESO, one of the sponsors of this webinar, provided some interesting data for us. And this data comes from a survey of about 2,600 EMS agencies, 911 records. And this is going to be all patient contacts, not just COVID contacts, but all patient contacts. And what we see here that really stands out is the rise in the use of eye protection and N95 respirators since the beginning of March, running through about April the 27th. So let's talk a little more about the PPE that's required. So when we are engaged in prolonged close contact with a known or suspected patient, prolonged being anything over a few minutes and close being anything within 6 foot of the patient, what's the risk to the provider? So in the first scenario, the patient is actually wearing a cloth face covering or a face mask. If the provider is wearing a surgical mask or an N95 or greater respirator, along with eye protection and gloves, the risk to the provider of being exposed and subsequently infected is low. If the patient is not wearing a cloth face covering or a face mask, or we're performing or present for aerosolizing procedures, so intubating the patient, nebulizers, suctioning airways, things of that nature. If we're present for those procedures and we're wearing an N95 or higher respirator, we've got our eye protection on, we've got our gloves on, and we've also got a gown on. So now we've upgraded our protection. If we're performing, taking those steps, then again, the risk to the provider is low. So I think one of the big takeaways here is that we need to control the source. All right, we need to put a face mask, not a respirator, but a face mask on all of these patients. If we'll do that and we'll take the appropriate PPE precautions, the risk to the provider is low. What about once we get the patient to the ambulance? Are there considerations that need to be made there? And there certainly are. So once we load that patient and the one provider is going to get into the driver's area, we want to make sure that we remove all of our PPE with the exception of the respirator or face mask. We want to continue to wear those while we transport to the hospital, but everything else should be removed and disposed of appropriately. If you have a divider, door, or window, feel free to close that. The ECS or environmental control system needs to be set to non-recirculate and high. The exhaust fan in the patient compartment needs to be set to high, and any outside air vents need to be open. There's been a lot of discussions about placing temporary barriers between the driver compartment and the patient compartment. That's not something that we've done in my organization, but we have spoke to several infectious disease physicians who feel that using the ECS non-recirculating system exhaust fans offer greater benefits over the use of temporary barriers. But in any case, if your organization wants to use something like an isopod or some type of a barrier, a temporary barrier between the driver's compartment and the patient compartment, that should be a departmental medical director specific decision that you folks make there with your own agencies. So here are really four of the most common respirators that we're seeing put to use right now in the pre-hospital COVID response. The first is what we refer to as an N95 FFR or filtering face piece respirator. The second, same type of device. Again, this is an N95, but now it has an exhalation port. And thirdly, we have a full face mask with the canister or cartridge filters. And then we've got the elastomeric face mask. Now, regardless of what you use here, they're all appropriate for use. A few things that you need to know. Prior to fit testing for any of these respirators, you have to have completed a medical questionnaire. So you can find an example of the medical questionnaire under the OSHA guidance. It's 1910.134 Appendix C. If you simply Google that term, you're going to see the form. That form has to be submitted to an appropriate healthcare professional to evaluate and sign off on. Could be your local physician, could be an occupational medical clinic in your community there. There are also online options that you can subscribe to, complete the questionnaire, submit it, and they'll usually turn those around in 24 to 48 hours. OSHA has issued some temporary guidance over the past several weeks where our PPE is concerned. One of the things they've done is they've temporarily suspended annual fit testing. What they have not suspended is initial fit testing. That's an important distinction because what that means is that new employees who have not been fit tested in your organization for the respirator type they're going to be wearing, they have to be fit tested, okay? The other thing I think that's important to note is that if you're going to move from one brand of respirator to another, you have to fit test because not all brands fit alike. One brand in a medium is not going to fit the same way in another brand's medium. If you're going to move from a filtering face piece respirator to either a full face mask or an elastometric face mask, you also need to be refit tested. And in that situation, with the full face mask and the elastomeric, you're also going to want to submit a new medical questionnaire with the appropriate box check for that respirator. When you're using the full face or elastomeric face mask respirators, please make sure that you follow OEM guidance related to cartridge changes, cleaning, disinfecting, and storage. It's important that we follow that, because what we don't want to have a poor fitting respirator. We don't want to store these respirators in a way that they are subject to cross infection. One more thing to note about respirators and fit testing, very important. You can't fit test in a beard. You can't have any facial hair at all that's going to impede the mask seal. The second point to be aware of is that there are no medical or religious exemptions where fit testing is concerned. If an employee cannot safely be fit tested and pass through a fit testing protocol, then they cannot be placed in an environment where they're exposed to these pathogens and these hazards. Hopefully, we don't get to a point we resort to this type of engineering. I'm not 100% sure what type of respirator this is. I've not seen this one before, and I've certainly not fit tested anybody for this type of respirator, nor have I fit tested anybody for this type of respirator. I think from a supply chain standpoint, we're going to be okay. We're going to get through this, and we're not going to have to resort to this type of PPE. When you're dealing with respirators, no doubt you've asked yourself, what are all these letters and numbers? What do they mean? Well, the letters indicate oil resistance. So if it's an N, it's not oil resistant. If it's an R, it's somewhat oil resistant. If it's a P, it's resistant to oil. What about the numbers? The numbers indicate the efficiency, the filtering efficiency. So the most ubiquitous or common mask respirator that we use right now is the N95. So that is not oil resistant, and it will filter at least 95% of airborne particles. As we've entered a crisis capacity, one of the things that's come out from OSHA is that we can use respirators certified in other countries. So, for instance, there are respirators that are produced under European standards, and these are typically referred to with two designations where the N95 and the P100 are concerned. If it's an N95, it's called an FFP2, and if it's a P100, it's referred to as an FFP3. Finally, some of you may have seen or may have used something called a KN95. This is the Chinese equivalent of an N95 mask, and I'm going to share some information with you on these foreign standards, these masks that are coming from outside of the country, to help you be able to vet them to make sure that they're not counterfeit and that they're appropriate for use. What about the rest of the PPE ensemble? We know that we have to have eyewear. We know that we need gowns. We know that we need gloves. So the eyewear will consist of a disposable face shield, goggles, or other protection which covers the front and sides of the face. So really, in an ideal situation, what we would like to see is a face shield. One of the benefits of the face shield is that it also provides protection to the respirator so that the respirator is not getting contaminated pathogens on it. If you're going to use a face shield, just make sure that it meets the referenced ANSI standard there. Same thing with the goggles. The caveat I think that I would offer to you on the goggles is that you want to use something that's got what we call an indirect vent. So this is the type of goggle. It does not have all of the perforations around the side. Again, ANSI standard, and you should see a D3 or a D5 designation associated with that goggle. Finally, as we get into crisis capacity, where PPE is becoming more difficult and more difficult, challenging to get, we can also use safety glasses. If you're going to do that, that should be one of your last resorts there. Again, let's make sure that it covers the sides of the eyes. And the last thing, regular eyeglasses. Regular eyeglasses or contact lenses are not appropriate. They do not provide the protection that you need. What about gowns? Gowns currently in use are disposable. They are typically coming in two styles. They're either fluid resistant or fluid impervious. We would like to have the impervious type, but that may not always be available. We've also referenced the standard by which these gowns are held to. And again, as we get into crisis capacity, a lot of areas, a lot of providers are already in a crisis capacity where PPE is hard to come by. We're actually starting to see scenarios where we are really saying, look, we're going to use gowns only during aerosolizing procedures. We're going to use face shields and goggles only during aerosolizing procedures. That's appropriate. The CDC has really laid that out in some of their documents, and we'll actually talk a little more about crisis and contingency standards here in a moment. And finally, gloves, double pair of disposable gloves, pretty straightforward. So one of the questions that I've been asked on multiple occasions is, well, when should I wear my PPE? If you'll remember, back in the early phases of our COVID response, we were talking about, hey, where have you traveled? Have you been to China? Have you been to South Korea? Where have you been? None of that matters now. COVID is here. It's community-based, and we have to treat all patients as PUIs. The question that I have for you is take a look at this graphic, pretty standard motor vehicle accident that any one of us could respond to. And you need to ask yourself the question, is this patient COVID positive? How do we know? So here's your takeaway. Surgical mask for all patients, that's your source control, minimum of a surgical mask for all providers. If we're going to engage or there's the potential for aerosolizing procedures, we need to upgrade to an N95 respirator or greater, appropriate eye protection, gloves, and a gown. Just remember, it's P plus P, patient plus provider, mask. All right, so what about CDC capacity strategies? Under normal operations, it's really kind of a one-for-one scenario for us, one set of PPE for one patient. We're not there right now. Unfortunately, large parts of the U.S. Are under contingency strategies, or even worse, we're under crisis strategies. So under contingency strategies, the CDC says that we can temporarily suspend annual fit testing. We've already done that. We discussed that. We can use PPE beyond the manufactured shelf life. Now, what I would tell you that we've done in my organization, we're using that type of PPE for fit testing. And any of it that happens to be left over in our stock, we are setting it back for a rainy day. If things got really bad and we had no more PPE left, we could go back to those expired stocks if we had to. And then, of course, the extended use or reuse of respirators. Extended use being you leave the respirator on for multiple patient contacts, probably not something we're going to see a lot of in the pre-hospital setting. Reuse of respirators. Right now, our organization is under a 5 uses per device or per patient, 5 patient contacts with the respirators. And there are some caveats to that, and I'll discuss those here in a moment. When we get into the crisis capacity standard, this is when we start to see use of respirators certified under foreign standards. We touched on that just a little bit ago. We're going to touch a little more on that here in a few slides. Limited reuse of respirators. A lot of us are already there. And then prioritizing PPE use. Again, if I'm going to be engaged or I think I'm going to be engaged in aerosolizing procedures, if I've got to intubate this patient, I need to be in goggles, a face shield, an N95 or greater. I've got to have a gown on. I've got to have gloves on. So danger. We remember the the TV show with Will Robinson and the robot. This is me to you, danger, danger. Your greatest risk as a provider of getting infected is going to come during your donning and doffing procedures. If you have not practiced and reviewed your donning and doffing procedures for your PPE, I beg you to do that. Please do that. It's real easy during your doffing procedures to inadvertently touch your mask, touch your face with a dirty hand, something like that. It's going to cause a cross infection. There's no reason for this. Please take your time during donning and doffing and review these procedures. In your downloadable document, we've provided a link to a video that will actually walk you through the CDC donning and doffing procedures. Please take some time to review that. And finally, as you're doffing, before you do anything, before you touch your face, before you touch that respirator, I want you to take 2 pumps of hand sanitizer and disinfect the gloves. Then start your doffing procedures. So let's talk in just a little more detail about this idea of extended use, reuse of respirators. As a lot of us are in crisis capacity, we don't have a large enough number of N95s to go 1 for 1. So the CDC tells us that there's no good way of determining the maximum possible numbers of safe reuses. We just don't know. They do offer some preliminary data, and what they're saying is no more than 5 uses per device. If you'll do that, that will offer an adequate safety margin. However, there's some caveats to that. In that process, if that mask becomes difficult to breathe through, it doesn't seal appropriately, or you have worn it during an aerosolizing procedure, you've intubated a patient, you've suctioned a patient, you had them on a neb, something like that, you got to throw that mask away. If it's soiled, if it becomes damaged, if it's wet, if it's got blood on it, any pathogens, anything like that, you got to throw it away. All right. So take a look at this graphic and just imagine that the area in the red circle is actually COVID pathogen. When you're doffing your mask, if you could actually see the COVID pathogen, would that change the way that you doff? So I want you to remember that graphic before you touch the mask, before you touch your face. Another piece of good data from ESO, and again, 2,600 providers, 911 records only, detailing all responses, not just COVID responses. And the interesting thing here is that we've seen close to a 50% increase in reuse protocols. What about disinfecting? There is, it's amazing. 6 weeks ago, if you Googled disinfect N95, you probably didn't see a whole lot of material out there. Now, it's everywhere. It's ubiquitous. People are talking about it all the time. So this material comes from the CDC, and these are 3 of the more commonly used disinfecting protocols for N95s right now. A matter of fact, my organization, we just subscribed to the vaporous hydrogen peroxide protocols to help disinfect our providers' N95s. The peroxide disinfecting protocol or fogging protocol shows a lot of promise. Lots of research out there on its efficacy and safety. What about ultraviolet light? A lot of folks, a lot of hospitals are using ultraviolet light. The caveat to ultraviolet light is that it may not kill all of the viruses, bacteria on the respirator. And the reason that is because it's prone to what they call shadowing effects. There's multiple layers of filter media in these N95s, and sometimes that light, that energy source can't penetrate through all of that. The other thing, there's some good information from the OEMs, folks like 3M, where they have some concerns about the impact of the UV lighting on the integrity of the mask itself. What about moist heat? Something to the tune of 140 degrees with 80% humidity. They say here that it caused minimal degradation in the filtration and fit performance of the mask tested. That's a good thing. One limitation, though, is that they're not sure about the disinfecting efficacy for various pathogens there. And then finally, some things that we don't want to do. We don't want to autoclave. We don't want to use dry heat. We don't want to spray them with alcohol. We don't want to put them in a microwave. We don't want to put them in the sink and try to wash them with soap and water. That's been tried. They've tested that extensively, and they know that it causes filter degradation. And I wouldn't want any of our providers out there putting those types of N95s on and putting themselves at risk. Now, here are things that we're definitely not going to do. We're not going to put it in the microwave at home, and we're not going to put it in the oven with dinner. What about counterfeit? No doubt you've all heard a lot about counterfeit PPE. There is, in fact, a lot of counterfeit PPE out there right now. As a matter of fact, my organization, we looked at 650 different providers of PPE from all over the world, and we could only get 3 of them vetted by the FBI. So that was very, very concerning. And, the FDA has done a nice job of providing us some resources to check the authenticity of the respirators to make sure that they're not counterfeit. We've provided those resources here for you. And if you look at the picture, here's an example of a counterfeit respirator that is not NIOSH approved. In fact, this one is NISH approved, and I've never heard of NISH as a certifying organization. So again, on the verification piece, here are some of the things that you should look for right away on your N95s. You should see a manufacturer name, a approver holder name, a registered trademark. If it's NIOSH approved, you should see NIOSH in block letters or the NIOSH logo. You should see a testing and certification number. You should see the filter and efficiency designations, NRP 95, 100, so on and so forth. What model number is it? Those 5 bullets are required to be on all N95s produced in the United States. Here's an example, and the hyperlink is in the downloaded document that's available for you. This is a CDC site where you can go in and put in some basic information about the PPE that you have or the PPE that you're looking for, and it's going to tell you something about its status. Is this on the counterfeit list or no? This is a simple graphic that's provided again by the CDC that you could certainly post or have at your disposal. One of the things that stands out to me is if you're looking at at purchasing N95s, or maybe you've got N95s in your stockpile right now that came from outside of the U.S. Look at the bottom bullet here: ear loops instead of headbands. N95s produced under NIOSH guidance do not have ear loops; they have headbands. So that's a dead giveaway right away. What about Decon? Again, Decon, a lot of emerging information. I have literally been covered up with emails about the newest and greatest products, this technology, that technology. There's a lot of material out there. Going to give you a little bit of guidance on that. So we're going to talk a little bit about UV. We'll talk about fogging, but the thing that you need to know there is that whatever you subscribe to there, it does not replace the standard spray and wipe. Using the right disinfectant, spraying it on a surface, waiting for a period of time, and then wiping up. We have to do that. There's no magic bullet here for us. So what about those approved disinfectants? Everything that we use in my organization comes off of something we call the N list, okay? And we've provided the hyperlink to the EPA's N list. Every chemical on that N list is approved for use against COVID. So take a look at what you currently have and make sure that it's on the N list. And if it's not, pick something off that N list, and you'll know that it's safe for use against COVID. So some general information. Some of this is going to be familiar to us. Some of this is maybe new or a refresher. So the first thing we want to do is we always want to review the safety data sheet associated with any disinfectant we're going to use. Some of these disinfectants can damage the interiors of the units, cables, things like that. They can damage our PPE. That's not good. A good example of that is there have been studies where they've taken bleach in greater than a 10% concentration and disinfected areas with it and found that it started to degrade the seams on the PPE. That's a good way to catch an exposure right there, so we don't want to do that. Let's make sure that we leave the doors on the ambulance open. We know that in that passive environment, the unit's not running, the environmental control system is not on. If we leave the door open, we will get about 6 air exchanges per hour over about a 10-minute period. So we want to make sure that we use appropriate PPE, gowns, gloves, a mask, and eye protection. Let's not have an exposure when we're cleaning the ambulance. Pre-cleaning. So we've got to clean the ambulance before we disinfect the ambulance. Disinfecting the ambulance is the process that we go through to actually kill or neutralize the microorganisms, those dirty pathogens. Cleaning is getting the blood, getting the dirty material out of the ambulance. So let's pre-clean first, and then we can disinfect. When we disinfect, we have to know something about the dwell time of the disinfectant that we're using. So again, you're going to want to take a minute, read the manufacturer guidance on the disinfectant, and it's going to tell you what the dwell time is. And what that means is once I spray that disinfectant onto the surfaces of the ambulance, how long does it have to sit there? If you're in doubt about what that is, you'll always go with 10 minutes. Spray it, let it set for 10 minutes, come back in and wipe that stuff up. Pay close attention to high contact surface areas. I think we all know about the floors, the seating, but what about radios? What about cell phones? What about clipboards? What about those little felt tracks that our cabinet doors slide back and forth on? Those are all areas that we need to pay attention to. And finally, when we're done with the decon process, we need to isolate and dispose of that contaminated waste in accordance with our standard operating procedures. What about fogging? My organization, we're actually using fogging. We're using fogging devices that are approved for use with a specific chemical. Not all chemicals are approved for use in fogging, so don't run out and buy a fogger from the local hardware store and throw bleach in it. Could be very dangerous. So you're going to want to make sure that it's approved for electrostatic fogging and that you're using the correct chemical. Now, when we talk about the fogging that's occurring here, what's happening is these are electrostatic foggers, so they're charging the decon solution, right? They're charging the molecules in the decon solution, positive charge. So now these positive charge, they oppose each other, just like you trying to push two 9-volt batteries together or two magnets. You know, they oppose each other. So what happens there is the surfaces that we're trying to disinfect are negative or neutral. So this provides a very, very even distribution of the fogging chemical. Again, review the safety data sheet on these chemicals. Make sure they're approved for use in fogging. Fogging is used in conjunction with standard spray and wipe procedures again. The OEMs on these fogging devices, they generally tell you it's a 20 to 60 minute cycle time for a single unit. Our experience, it's taken us about 30 to 40 minutes to adequately fog an ambulance. Here's the ultraviolet lighting or the ultraviolet germicidal irradiation technique again. I know that there are a lot of folks out there using this. A couple of things about it is that we still have to worry about the shadowing effects here. If the light can't get to the surface, it's covered or it's concealed, it's not going to get disinfected. So you're going to have to move that unit around. I have seen here recently that now they've got, we're starting to see more of these units that are able to actually be installed in the ambulance as a part of a permanent disinfecting process. I think that's pretty interesting. So what about our uniforms, our boots, things like that? We have to consider these items when we talk about disinfecting. If you've had an exposure, don't take those dirty uniforms home to your family, okay? Just don't do that. Hopefully you're all in a situation where you can launder at your base or your facility. You want to keep extra uniforms on hand. Infected uniforms and linens, it's really a standard launder here. There's nothing special that needs to be done. Put them in hot water, something at or greater than 160 degrees. Launder them normally. The CDC goes as far to say that if you want to throw other clothing, non-contaminated clothing in there, you certainly can. So nothing special here on laundering. I would not advise you that you transport infected linens or uniforms home in a red biohazard bag. I think that you'll probably scare the neighbors a little bit if you do that. They're going to be wondering what you're dragging into the neighborhood there. And finally, don't forget to disinfect your boots. Where your boots or your footwear is concerned. A mild detergent, again, the pre-clean process. So do that first, and then go ahead and use whatever disinfectant you happen to be using. It could be a mild form of bleach that you spray on the soles of your boots, or a commercially available disinfectant that you're using. Just spray that on the soles of your footwear, and that should be sufficient to make sure that your footwear is disinfected. And finally, there are no emergencies in a pandemic. So this is not the time for us to throw good common sense out the window. It's not the time for us to abandon our good safety common sense. Slow down, and don't forget what we all learned as young EMTs and paramedics: is the scene safe? Don't go out there and put yourself in harm's way, get an infection, and bring it home to your family and friends. Please don't do that. Take a minute, think about what's going on, slow down, take your time with your donning and doffing procedures. We're going to get through this together. So what's our first priority here? You are. Each one of you brings a tremendous amount of value to the EMS community. And again, we need you to come home safely. Take care of yourselves, take care of each other. And as I said a moment ago, we're all going to get through this at the end of the day. Thank you.
Thank you very much, Mr. Baldwin. We appreciate all of your time and expertise. All of the resources that are listed on the slide that's on the page will be in the download for everyone. We really appreciate your time and expertise. So thank you for that. Do you have time for a few quick questions from the field?
Yeah, absolutely.
All right. So it looks like we had a management perspective question that came in. The question was, how do we talk to our frontline employees when guidance and availability is changing so rapidly?
Yeah, that's a great question. So I'll tell you what we've done here in my organization. We set up a COVID website. Any of you can go to that COVID website if you'd like. We update it all of the time. To your point, the information evolves, it changes quickly. If you go to globalmedicalresponse.com, you're going to see the COVID banner there. Click it, and you can access any of the material that we have in there. So my point there is have a central place for documents, assign somebody or a team of somebodies to monitor for changes. And then here's probably the most important thing that I would offer you. Be honest and transparent with your employees when you're talking to them about the COVID response. Look, I'm faced with the same challenges. We don't always have all the answers. And sometimes the hardest thing for us to do is to say, I don't have the answer, but you know what? I will do my level best to go find the answer.
Okay, great. That's super helpful. Let's see, we had some other questions come in related to disinfectant. So one of the questions was, for disinfectants, would it be appropriate to spray it on and leave it, or should it always be wiped off?
Yeah, so again, you have to know what the dwell time is. So again, the dwell time is how long do we leave the disinfectant sit on a contaminated surface. It could be a minute, it could be 3 minutes, it could be 5 minutes. It really depends on what the manufacturer's label calls out there. So you want to look at that. And again, if there's any doubt about what that dwell time should be, the general rule of thumb is 10 minutes. So leave the disinfectant, sit on the surface for 10 minutes, and then go back and wipe it up.
Okay, great. Thank you for that. So it looks like we also had a very specific question related to fogging and aircraft. So the question was, is it applicable to use in an aircraft?
Yeah, great question. So early on, we actually did some testing with foggers in our fleet. We also consulted with the aircraft manufacturers, and we learned a few things right away. One, the chemical can be corrosive or dangerous to the avionics, to the radios. So that's a problem. And then the other problem is that it gets onto the interior of the windscreens and the windows and is extremely difficult, if not impossible, to get off. So that's a big problem. In talking with the manufacturers, they didn't recommend the use of UV light or foggers on the aircraft for some of those reasons. So the GMR air fleet is not using foggers or UV light on the aircraft.
Okay. All right. Thank you very much. So I did see a lot of questions coming in related just generally to clothing and boot decontamination. So is it possible for you to expand on the proper cleaning of clothing? We know you said not to bring it home, but the proper cleaning of clothing and then the proper decontamination of your boots.
Sure. Again, if you know that you've had a contact, you've got gross contaminants on the uniform, you're going to want to get that off, as you normally would if it was blood, something like that. Have extra uniforms on hand. Hopefully you're in a scenario where you can launder at your station. Again, hot water is really all that's called for, something at 160 degrees or higher. And standard detergent. If you want to go the extra step, there are sanitizing powders for laundry use available out there that you can use to augment your normal detergent. Really, that's all that's called for on the uniforms. If you're using protective turnout gear, that's a whole different ball game. You guys should know that there are NFPA standards that really dictate how that personal protective clothing should be cleaned. That's a different scenario there. And then where your footwear is concerned, again, just use a mild detergent to do the pre-cleaning, and then follow that up with a disinfectant, and then wipe it off, and you're going to be fine.
All right. Well, it looks like we're running short on time, so I wanted to again extend a thank you to you, Tom. We know you're a very busy man, and we appreciate your time.
Thank you for having me. It's truly an honor to give back to the community that I've been a part of for some 30 years now. I certainly appreciate it, and please, to each one of you providers out there, be safe out there. Let's take care of each other, and we'll get through this.
We hope that everyone found value in today's presentation. Thank you once again to our sponsors, Life Assist, McKesson, and ESO for their support. A recording of today's webinar will be posted on our NAMT website. Once it's available, navigate to namt.org and click on the Events tab, and then EMS Webinars and Podcasts. We will send a follow-up email to attendees when the recording and the FAQs are ready. Mr. Baldwin is going to get through the rest of the questions and answer them, so we'll post them on the website for you guys to take a look at. In about an hour, you'll receive an email from the webinar platform requesting that you fill out your evaluation from today's webinar, and it will give you the information on how to apply for your CE. Note that it takes roughly a month's time frame for us to process and verify continuing education credits, so you will not receive your certificate right away. This concludes our webinar. May you, your college, your community, and your family remain healthy and safe. Thank you and have a great day.